So the next speaker is Dr. Cherdchai. He is the HPB surgeon, the rookies one in Radviti Hospital. He will give a lecture with the ERAS protocol in liver surgery, optimizing patient outcome. So please give him a hand.
Okay, I think today we spend the entire day learning about the surgical technique. So for the final lecture, I conclude the topic of the patient care after hepatectomy. And first of all, I thank you to MESDA to invited me to share the insight on the ERAS implementation today. I have nothing to disclose. Today's presentation, I will begin with the introduction and followed by the brief summary of the current ERAS recommendation. And then I discuss on the critical outcome of the and benefit of the ERAS, and will conclude with my protocol ERAS in my hospital. The ERAS, or Enhanced Recovery After Surgery, this is a multimodal evidence-based program that designed to reduce the surgical stress with associated with increased morbidity and prolonged hospital stay. The ERAS program was last updated in 2022 and followed previous version in 2016. This diagram I show you is the item in the ERAS program, which cover in every phase of the patient care, includes the preoperative, intraoperative, and postoperative phase. Next, I will provide a brief summary of the ERAS recommendation to anyone. The recommendation is categorized based on the evidence levels and grade recommendation, weak to strong. The determination of the recommendation is reliability on the available evidence. And you should do the ERAS recommendation and decide what to do or what is not do it. First I start with the preoperative counseling. The ERAS recommendation suggests to use the brochure and multimedia, as they are more effective than the verbal counseling alone. However, the evidence level is low and recommendation is weak. For rehabilitation, the ERAS recommended it for the high-risk patient, such as elderly, malnourished patient, and overweight, or smoking or psychological disorder patient. It should ideally be done 4 to 6 weeks before surgery. The evidence level is moderate and recommendation is remain weak. For preoperative biliary drainage, the recommendation is perform drainage in patient with bilirubin level is greater than 3 mg per deciliter, and prefer to use the percutaneous biliary drainage route over the endoscopic drainage. The evidence level is moderate and recommendation is strong. For preoperative smoking and alcoholic cessation, the ERAS recommend to stop smoking at least 4 weeks before surgery and stop the alcohol consumption for more than 4 to 8 weeks. This recommendation is strong. For preoperative nutrition, the recommendation the nutritional assessment for all hepatic surgery patients, and the criteria for malnutrition includes the patient with a weight loss more than 10% or 5% within 3 months, or a patient with a low BMI. For this patient, enteral supplementation is recommended. For 7 or 14 days before surgery, the evidence level is high and recommendation is strong. For perioperative oral immunonutrition, the oral immunonutrition refers to the use of the branched-chain amino acids and L-arginine and omega-3 fatty acids to reduce the inflammation and enhance liver function. But you see, however, according to ERAS, it is not recommendation due to lack of the supportive evidence. The evidence level is low and recommendation is weak. For fasting and carbohydrate loading, the recommendation for fasting is for 2 hours for the liquid and 6 hours for solid, with a moderate evidence level and a strong recommendation. And for preoperative carbohydrate loading, the effect on the hospital stay is remain unclear, with the low evidence level and weak in the recommendation. For pre-anesthetic medication, recommendation is to avoid the long-acting anxiolytic such as benzodiazepine and gabapentin, as well as NSAID group. Meanwhile, acetaminophen and hyoscine could be used, but you should use it with caution. The evidence level is moderate and the recommendation is strong. And for antithrombotic prophylaxis to prevent the DVT or the deep vein thrombosis, the recommendation is to use the low molecular weight heparins or unfractionated heparins if this patient has no contraindication. Additional intermittent pneumatic compression is also recommended. The evidence level is moderate and the recommendation is strong. For preoperative steroid, ERAS recommend to use the single shot dose of the 500 mg methylprednisolone to reduce the postoperative complication. However, due to limited of the evidence, the recommendation is remain weak. For the antimicrobial prophylaxis, the recommendation is use the antibiotics within 60 minutes before incision and not recommend to use in the post-op in the routine case. However, in case that involuntarily reconstruction, the ERAS suggests to perform the bile culture, but the optimum duration of the antibiotic use is remain unknown. In some study, they suggest the 2-day course of the antibiotics, but the evidence level is in the recommendation is moderate and recommendation is weak. For skin preparation, the guideline recommend to use the chlorhexidine with alcohol over the povidone iodines. This comes with a strong recommendation. And for minimal invasives, the evidence suggests when the minimal invasive performed by the appropriate training team, it can reduce the postoperative length of hospital stay and the complication. This comes with a strong recommendation. For epidurals, intravenous and oral analgesia, the ERAS recommendation to use the epidural analgesia and the multimodal analgesia. This benefit of this pain control is particularly benefit for the open liver surgery. And you can see the grade of recommendation in laparoscopic is big, is benefit in the open more than laparoscopic. Some anesthesiologists may be familiar to use the continuous wound catheter infiltration and transversus abdominal plain tap or tap blocks. This evidence that this technique can be provide pain relief comparable to the epidural analgesia with the low of the complication compared with the epidural analgesia. It comes with a strong recommendation. For go-direct fluid therapy, the recommendation is maintaining the low central venous pressure to reduce the blood loss during the liver resection, and prefer to use the balanced crystalloid while optimizing cardiac output and end organ perfusion. The grade of recommendation is strong. For postoperative nausea vomiting, if your patient have the risk factors such as the history of the postoperative nausea vomiting, being a females or the younger age, ERAS recommend to use a preventive strategy by use the at least 2 prophylaxis antiemetics. The grade recommendation strong. This table they show the medication and the doses used for postoperative nausea vomiting. So the ondansetron, dexamethasone, you can use with suggest to use at least 2 antiemetic agents. For preventing the hypothermia, they recommend to maintain the temperature about 36 degrees Celsius to reduce the both cardiac and non-cardiac complication. The multimodal approach includes a warming garment and forced air warming system is advised. This comes with a strong recommendation. For prophylaxis, nasogastric intubation, ERAS does not recommend in the routine use. It provides no benefits and may increase in the hospital length of stay. This comes with a strong recommendation. For prophylaxis, abdominal drainage, the ERAS does not recommend in routine use in a hepatectomy, whether with or without biliary reconstruction. But the decision is made case by case on basis. It comes with a strong recommendation. For artificial nutrition and early oral intake, early oral intake is recommended in this guideline, but artificial nutrition is maybe necessary in the patient who have malnourished, who require the prolonged fasting, and who have the liver cirrhosis. And they prefer the enteral nutrition over the parenteral nutrition. This recommendation is come with the strong. For stimulation of the bowel movement, some evidence suggests to use that the laxatives, gum chewing, and some kind of the herbal medicines that maybe shorten the time of the first phases. However, due to the lack of the strong supportive study, this recommendation remain weak. About the postoperative glycemic control, the ERA suggests to keep the normal glycemia. They define the blood glucose level around 150. It comes with the strong recommendation. For preventing the delayed gastric emptying, some studies suggest the use of the omentum flaps to cover the cut surface of the liver may be held to reduce the delayed gastric emptying, especially in the left side of the liver resection. However, the recommendation is remain weak. For early mobilization and schedule to mobilization, it should be done immediately after surgery and continue until discharge. This is the strong recommendation. Okay, that's the conclusion of the summary of all the ERAS recommendation. Next, I will discuss the clinical outcome of the ERAS protocol. I have include the 3 study in my review. The first study is an observational study to compare the non-ERAS and the ERAS group. The result that show the ERAS group reduce the minor complication, and in the outcome you see the minimal invasive group maybe benefits more than the open surgery group. The second study is the systematic meta-analysis in the patient study in the patient with cirrhosis, which found that the ERAS group can reduce the minor complication and shorten hospital stay. The third study is a prospective observational study with use the propensity score matching. They comparing the ERAS and the non-ERAS groups. The results show the same. The ERAS can reduce the general complication and the infectious complication. So the summary of the 3 study. In overall, the study indicated that ERAS can reduce the minor complication and the shorter hospital stay. However, it cannot be completely prevent from the major complication associated with the reverse surgery. Then I think the ERAS cannot replace the good surgical technique, but it serves as a vulnerable tool to facilitate the smooth recovery of this patient. In practicing the full implementing of every aspect that I say, every recommendation on the ERAS can be challenging. Therefore, I think to having the protocol and the checklist is essential to ensure the patient can be aligned with the ERAS principle as close as possible. This is a flowchart in my hospital. You can see the patient begin with the ERAS protocol is begin with outpatient clinics. The surgical plan and schedule for surgical days are determined. And the ERAS team, which include the nutritionist, the physiologist, and anesthesiologist, and the other subspecialty that's involved, is active to involve the patient optimization. And then patient reassessment will be conducted in the 2 weeks later, and followed by implementation the pre-operative order, intraoperative strategy, and the post-operative protocol to ensure to adhere the patient with the ERAS principle. This show the checklist from my hospital, which includes in the red box. You can see this in the patient assessment checklist about the nutrition, ECOG score, and part history, and the green box is a multidisciplinary team checklist to ensure the patient comprehensive the ERAS protocol implementation. And I really recommend you to setting up the preoperative order for hepatectomy, to around and adjust based on the specific context and the resource that you have. And post-operative orders too. In summary, the flowchart begins with a multidisciplinary team to approach before surgery, include the preoperative patient optimization with the breathing exercise, education, and after that with the good surgical technique and anesthesiologic technique, and well coordinated with the postoperative care team with the early ambulation. The patient are expected to recover well in line with the ERAS goal. Okay, these are finals to summarize. The ERAS includes the key recommendation that cover in all phases: preoperative, intraoperative, and postoperative. The well implementation of the ERAS protocol can reduce the surgical trauma and accelerate recovery and shorten hospital stay and improve quality of life of your patient. Okay, thank you.